Good afternoon and welcome to the teleconferencing session, the second session which we are going to conduct for post-basic BSc nursing students of Indira Gandhi National Open University. We are going to now discuss about the mental health and psychiatric nursing, and in mental health and psychiatric nursing also we thought we will discuss more about the affective disorders, and under affective disorders we will talk of two major conditions which you will come across in the hospital, in the ward setting and in the community. That is patients who are suffering from excitement, and the patients, and in session the last session, which will be from 1 to 1:45, will discuss about the patients who are suffering from depression. Now these are the two major affective disorders, but before I discuss affective disorders, let me introduce the experts to you. On my extreme right we have Mrs. Annie Kumar, who is a senior faculty at College of Nursing, Lady Hardinge Medical College. The name will be given to it on 11th probably of September. On my immediate right we have Mrs. Reminder Kalra, who is again a senior faculty at REC College of Nursing, University of Delhi. Welcome to the studio, and we are very happy to have you, because I'm sure the students are going to have lot of interesting description about these kind of disorders, because you have a rich experience in the mental health nursing. So without wasting time, I thought let us first talk about what is this affective disorders and how would you differentiate from the functional disorder, Mrs. Reminder Kalra.
Thank you, ma'am. The term affective is not a new term for you. During psychology, when we were studying psychology, that time also we've learned about the affect component. When we talk about the behavior, it has got three components, that is thought, affect and the cognitive. Cognitive, and affective. Cognitive is related to thought, cognitive is related to motor aspect, and affective is related to our emotions, our feeling tone. In the previous chapter you must have studied about the thought disorder, which is schizophrenia. Group of disorders which are there under that is schizophrenia. But when we talk about affective disorders, they are the ones in which the emotions, the feeling, the mood, these things are getting affected. Now many times we also experience feeling of sadness, we also experience feeling of happiness, but that is within limits and there is a reason to feel happy or to feel sad. But when there is alteration, there is some abnormality in expression of those, then we say it is affective disorder. If we see to the definition of affective disorder, mental illnesses in which mood change is primary and dominant feature. That means there is disturbance in the affect and the mood. Affect is the shorter duration, and when it is persistent for a longer time, that is mood. So there is mood change which is primary and dominant feature. Mood change is relatively persistent. That means if the person is feeling sad, it is not that feeling sad for temporary moment, but that sadness remains persistent, and there is that is primary and dominant feature. Mood change is persistent and is associated with characteristic changes in thinking, attitude and behavior. When we also feel sad, we start getting some negative feelings. Our attitude also becomes negative. Our behavior gets affected. We may not feel like getting up and doing work. Similarly, when the patients are suffering from affective disorders, the other components, their thoughts also get affected, their attitude and behavior also start getting affected. No, I'm not going to get well. Negative thoughts, they come into the mind. It's better to die than to have such type of illness. And they also have negative attitude that I cannot get well. Even in the motor aspect, the things are getting affected. That is affective disorder.
And I was saying we will differentiate from functional or schizophrenia, because the major difference between the schizophrenic or functional disorder with that affective disorder is that thought is predominantly affected in case of the functional disorder or major schizophrenia, and in case of affective disorder it is a mood. Of course, as you mentioned that along with the mood, the cognitive and the affective, cognitive, everything gets affected, and that is true with the thought disorders like schizophrenia also, but the major predominance is thought disorder in case of schizophrenia, and in case of affective disorder we have the mood which gets affected mainly. What are some of the causative or causes which we can elaborate?
When we see to the causes or the etiological factors which cause to depression, which cause to the affective disturbances, one is biological factors. There you must have seen that sometimes so there are certain illnesses which run in families. Another reason, biochemical, now when we talk about biological factors, there are two things under that, that is biochemical factor and genetic factors. We have drugs which are found effective, and they are the ones which are affecting epinephrine and serotonin. It is thought that disturbance in epinephrine and serotonin can cause functional deficit, where the specific nerve cell synapses they are associated with depression. Decrease in this can cause depression, and increase in these things can cause mania, or there is an elevated mood seen in it. Now, so these are the biochemical factors, and especially when we find the drugs being affected, the drugs which are affecting serotonin and norepinephrine, they are effective in treatment of affective disturbances. So this also shows that there is definitely some biochemical factor which is causing this problem. Another factor is genetic factor. It is found that manic depressive disorder runs in families. If suppose one parent is suffering from mental affective disorder, there are 25% chances that the children might have this disorder. But if it is both the parents, like mother and father, both having affective disorder, there are 50 to 75% chances that the children might be suffering from mental disorder, from affective disorder. And you must have seen that sometimes when you get the patients also, you ask their family history, and they might report that yes, their father or their mother or some blood relation had been suffering from affective disorders. That also, but it is not must that everybody who is suffering from affective disorder, it is must that they need to have family history. It is not must. Then there are other factors like physical factors, like you must have seen that certain drugs, like when the person is put on hormones, person being put on sedatives for a very long time, person who is put on antibacterial, especially like when the patient is on long-term treatment like ATT for tuberculosis when it is given, these drugs can also cause the person going into depression. Then certain infections like viral infections, hepatitis, and there are various infections which can also cause depression. Another factor is psychosocial factor, which we are all very familiar with, that any kind of stress, any type of societal pressure, we find that there are a lot of cases, there is increase in depressive cases being reported so often. There are increase in societal cases because people are facing a lot of stress with new development coming, with new technological changes coming, the stress level is increasing, and these things, they cause lot of effect on the health of the individual, and it also causes mental disturbances, and it may sometimes appear in the form of major depressive disorder also. Then stress, other than stress, we have sometimes if a person suffering, which may not be one factor, but it could be the combination of factor, like there is a family history but the person might not be suffering, but when there is some severe stress, this person is more prone to develop affective disorder than developing any other type of illness.
Because of the potential. Yeah. That means the person is, that particular stressful situation triggered off the affective disorder in an individual and was not able to cope up, but dormant for developing that kind of a disorder, predisposed to develop that kind of a disorder. Well, let's discuss some of the, because you're talking of mania and depression together, so let's talk of the manifestation of mania and depression if you are putting together. Would you like to put it together? Let's talk of mania first.
Yes.
We'll talk about mania first. Okay.
When we talk about the manifestations, the symptoms which might be seen in this patient, we can have emotional, cognitive, motivational, behavioral and physical. When we talk about the emotional, there will be elation, liking for self and increased motor response. When you must have studied about psychopathology, when we discuss, there we have elation. Elation is that there can be pleasurable disorder, pleasurable affective disturbances, which can be euphoria, elation, exaltation and ecstasy. Euphoria is increased feeling of happiness. But when the feeling of happiness is exaggerated and it also moves into the drives and it also starts affecting the motor activity of a person, psychomotor activity is affected, then we say it is elation. And when there is elation accompanied or increased happiness, feeling of happiness, air of enjoyment accompanied along with illusion of grandiosity, then that we say it as exaltation. And when it is that sometimes the level of affect may increase further. The person starts having religious feelings and start feeling that he's very close to the God, he's loved above all, and he is in tranquil sense of well-being. That we call it as ecstasy. So under emotion it can be euphoria, elation, exultation, and ecstasy. There is liking for self. Person start feeling, actually there may be the basic drive, the basic component may be low self-esteem, which a person does not accept, and may come it as in the form of liking for self and increased motor responses. Under cognitive, there can be positive self-image, that yes, I can do so much of thing, I have a lot of capacity to do. Positive expectations. Now I have appeared for the exam, I know that I am going to get this much percentage, I am going to top. Maybe the person might not have that potential, maybe the person has not put in efforts but has lot of expectations from himself. And they also have tendency to blame others. Since they have lot of expectations from themselves which they will not be able to achieve. When they are not able to achieve, there is a tendency that they put the blame on others. And there is also denial of problems. No, I don't have any problem. I am all fine. I have got so much with me that why should I be troubled at all. They can also be arbitrary decision making. They may be very superficial in decision making. They may not be thinking the matter into the depth and then taking the decision. They may be very quick in taking the decision, but that is superficial decisions which they take. Then under motivational manifestations, they have driven and impulsive behavior. That means out of impulse they take, they show action. It is not that they think and then they act. Normally, if we are in any situation, we think, we analyze the situation and we react to it. But these patients, immediately, without thinking, they will take the action. Then action-oriented wishes. I want to go, so the person it says, I want to watch television even after the hours that it is permit. Patient may be just standing on the duty room, sitting over your head and saying repeatedly, no sister, how can you stop? This is our country is independent country, we have the right to watch TV. Who says that we cannot watch? That may be their argument. Then drive for independence. You cannot make them restricted. They want that they should be left independent. And desire for self-enhancement. I'll do this much, I'll start a business. They may be demanding from parents, you give me this much of money, I will make your money to multiply like anything. There may be a lot of demands that they are putting. Under behavioral manifestation, there will be hyperactivity. You will find them just running around here and there. They'll be just not stopping even to sit and have food. They may not sit and have food. They may not like to go to the toilet. They may develop constipation as a result of that because they think it's wastage of time. Or it could be that they are, since they have a lot of increased activity, they do feel hungry but they are not doing those, they don't want to sit and eat food. So we'll discuss in nursing man interventions how to discuss. Then loudness. They may be speaking in a loud voice. Under physical symptoms, they can be infatigability, increased libido. Their libido is increased. They may be talking about all vulgar things, cutting the vulgar jokes in the ward, and maybe passing, sister, you're looking so sweet, you're looking smart. And then there can be insomnia. Because of increased activity, though they are exhausted, but they may not like to go to the bed and sleep.
I think the very important essence what you have mentioned is that there is a change in the emotion, there is change in cognition, motivation, behavior and physical factors. But sometimes it is also said that they have got major triad symptoms, three symptoms which are there, that is increased mood or elevation of mood, increased activity and pressure of speech. So these are the three things that covers up the cognitive level, the affective level and the activity level. That is why probably it is seen that in these patients, like you were saying, that the person has marked insomnia, is not able to sleep and is asking the sister to allow her some of the pressures which he could create. Also their jokes are very infectious and the people just cannot avoid but laughing on the jokes which they cut, and this is where one has to be very careful as a nurse when you are dealing with these patients. And we have a number of those examples which we can share when we talk about the nursing management. Before that, let us talk about ICD-10 classification. Before we go into mania and its types in detail, we can talk about ICD-10 classification.
When we talk about ICD-10 classification, ICD-10 is the latest classification which is being followed worldwide. You have got specific numbers being given to the specific disorders, and there the symptoms are listed with each disorder. Now under ICD-10 classification, affective disorders are classified from F30 to F39. F30 is manic episodes which can be hypomania. When the mania is not so severe, it is little less than mania. Then mania without psychotic symptoms. Usually delusions and hallucinations are taken as psychotic symptoms. They may, usually manic patients may have a lot of grandiose delusions and lot of auditory hallucinations, which are more common than visual hallucinations. Once it is without psychotic symptoms, and another one can be mania with psychotic symptoms.
Yes, Jaipur. Hello.
Good afternoon, ma'am.
Good afternoon.
मैम मैं इग्नू रीजनल सेंटर जयपुर से बोल रहा हूँ
जी।
प्रकाश गुरु
जी।
माय एनरोलमेंट नंबर इज 060834369। मैम प्रॉब्लम इज कि मेरा मैडम जो वो है मार्क्स कार्ड,
हाँ जी,
उसके अंदर मैडम नंबर नहीं है।
नहीं, आप
तो मैडम उसमें ना तो असाइनमेंट का नंबर है, ना इसमें कोई एग्जाम के नंबर है, ना प्रैक्टिकल के नंबर है।
नहीं तो आप
उसका क्या होगा?
आपको टर्म एंड एग्जामिनेशन के सिर्फ मार्क्स मिले होंगे, सिर्फ टर्म एंड एग्जाम है ना, बाकी मार्क्स नहीं मिले हैं आपको। ठीक है, वो हमें पता है। वो थोड़ा ग्रेड कार्ड फाइनलाइज करने में टाइम लग गया था, तो अब वो ग्रेड कार्ड जो है पेपर नहीं था, प्रिंट पेपर, तो अब ग्रेड कार्ड्स वो लोग बना रहे हैं। सिर्फ आपके साथ ही ऐसा नहीं, किसी को भी नहीं मिला। आपके फ्रेंड्स को क्या मिला है?
अभी तक मिला नहीं
जी। मेरे को पता है इस बात का कि आपको किसी को नहीं मिला है, और रजिस्ट्रार साहब हमारे SRE डिवीजन के उसको देख रहे हैं, और जल्दी से जल्दी सबको मिल जाएंगे। किसी को भी नहीं मिला ऑल ओवर इंडिया, तो आप चिंता मत कीजिए। हो सकता है कि इस हफ्ते, इस महीने के आखिर में सबको ग्रेड कार्ड मिल जाएगा। मैं दोबारा पता कर लूंगी। जी
जी मैम।
जी
सेकंड मैम,
हाँ जी,
ये जो जून के जो एग्जाम हुए थे उनका रिजल्ट आया नहीं है मैडम?
जी, मैंने शुरू में ही बोल दिया था कि जून के रिजल्ट का भी, जून के एग्जाम का रिजल्ट नहीं गया। कल भी मैंने रजिस्ट्रार साहब से बात करी थी SRE डिवीजन में कि जून का हमारा स्टूडेंट्स का रिजल्ट नहीं गया, और सितंबर में नए फॉर्म भरने हैं, तो स्टूडेंट्स कैसे भरेंगे। आप एक काम कीजिएगा, आप उसमें देखिए फॉर्म तो सारा, पर अगर फॉर्म भरेंगे तो आपको पैसे भी देने पड़ेंगे। अब तो 50 रुपए पर कोर्स आपको फॉर्म भरने में लगने चाहिए। तो कल मेरी बात हुई, नहीं जी, जो कोर्स आप कोई भी फॉर्म भरते हैं एग्जामिनेशन का, तो अगर रिजल्ट नहीं अनाउंस हुआ और आपको पता नहीं है कि आप पास हुए हैं कि नहीं हुए हैं, और उन तीनों कोर्सेज का, सेकेंड ईयर के तीनों कोर्सेज का आप फॉर्म भरते हैं, तो आपको 50 रुपए पर कोर्स उसके साथ एग्जामिनेशन फी देनी पड़ेगी। तो आप एक दिन कल का और वेट करिए, मंडे को मैं दोबारा रजिस्ट्रार साहब से पूछूंगी कि क्या रिजल्ट नेट पे डाले हैं कि नहीं, क्योंकि मेरी बात ये फ्राइडे को भी हुई है कि हमारे स्टूडेंट्स का रिजल्ट अभी किसी भी सब्जेक्ट में अनाउंस नहीं हुआ, और एग्जामिनेशन फॉर्म नहीं भरने, तो वो कैसे भरेंगे जबकि हम फीस चार्ज कर रहे हैं। ठीक है, तो आप ये हम
फीस मैडम उसमें ये है कि जो आपको फॉर्म से लिखा हुआ है, जो ड्यू पेपर था उसकी फीस नहीं लगेगी, और जो आप नए जैसे हम BSc सेकेंड ईयर के हैं तो उसके 3 पेपरों की फीस लगेगी, 3 प्रैक्टिकल की फीस लगेगी, बाकी जो ड्यू पेपर था उसमें लिखा हुआ नो फीस।
नहीं, ऐसा नहीं है। एग्जामिनेशन फॉर्म जब आप भरेंगे तो 50 रुपए पर कोर्स है। आप जरा नेट में देखिए, अब आप क्योंकि रीजनल सेंटर में बैठे हुए हैं, तो आप हमारे ARD से भी बात कर सकते हैं, वो बता देंगे आपको। 50 रुपए पर कोर्स फीस देनी है। ठीक है, तो आप उस फॉर्म को अच्छी तरह से पढ़िए, और आप ट्यूसडे वेडनेसडे को आप एक बार फोन कर लीजिए। मेरा लैंडलाइन नंबर है 29532965, उस पर फोन कर लीजिएगा, तो मैं आपको बता दूंगी एग्जैक्टली कि क्या डिसीजन हुआ कि टर्म एंड एग्जामिनेशन मार्क्स सेकेंड ईयर के नेट पे डाल दिए कि नहीं डाल दिए। ठीक है, तो आप थोड़ा सा वो देख लीजिए। ओके, आप ये सुनिए, जो फॉर्म है हमारे, इस फॉर्म में बड़ा क्लियरली मेंशन करा हुआ है कोर्स कोड्स विद इन ब्रैकेट, ये वाला फॉर्म मैं दिखा रही हूँ आपको। ठीक है, इसमें लिखा हुआ है कोर्स कोड्स within bracket exams already taken in the last term and examination but results awaited on the date of submission of the exam form. For results please no exam fee to be paid. जो आपके सेकेंड ईयर के एग्जाम के पेमेंट होगी वो नहीं देनी होगी क्योंकि उसका रिजल्ट नहीं निकला है, वो हमारे सिस्टम की तरफ से डिले है, इग्नू की तरफ से डिले है, ठीक है। पर जो नए एग्जाम आपने देने हैं थर्ड ईयर के उसकी आपको फीस पे करनी पड़ेगी। आई होप आई हैव मेड इट क्लियर टू यू। अगर क्लियर नहीं है तो आप प्लीज दोबारा पूछ सकते हैं, यू आर मोस्ट वेलकम। थर्ड ईयर के जो कोर्सेज हैं आपके कम्युनिटी हेल्थ नर्सिंग, नर्सिंग एजुकेशन रिसर्च, नर्सिंग एडमिनिस्ट्रेशन, उसकी पेमेंट आपको देनी पड़ेगी 50 रुपए पर कोर्स। पर जो सेकेंड ईयर के आप एग्जाम दे चुके हैं और उसका रिजल्ट नहीं अनाउंस हुआ है तो उसके लिए फीस नहीं पे करनी पड़ेगी। ओके, with that we go to the next one. We were talking about the ICD classification and she's just mentioning, and then we will go back to the mania and its types in detail. So just quickly let's
F31 is, thank you ma'am, F31 is bipolar affective disorder, currently hypomanic, manic, depressed, mixed in remission. We'll come back again to this. F32 is depressive episodes mild with or without somatic symptoms. Somatic symptoms are the physical complaints which the person has. It can be moderate with or without somatic symptoms. It can be severe with or without psychotic symptoms. F33 is recurrent depressive disorders which can be mild, moderate, severe in remission. Then F34 is persistent mood disorders which is cyclothymia and dysthymia, and F38 is other mood disorder that is recurrent brief depression. See, when you talk about affective disorders, it can be that the person might be having mania, person might be having depression, or it can be that the person has got mania and then sometimes in between the person has got depressive episode. In bipolar affective disorder, there are episodes of mania and depression both occurring, but it is not must that at times it is mania and next time is depression. It could be sometimes 2 episodes of mania or 3 episodes of mania and then another episode of depression. But there is no fixed pattern of that. But when you have both mania and depressive episodes occurring together, then we call it as bipolar affective disorder. If it is only depressive disorders occurring, then we call it as unipolar disorder. But if it is manic episode, even if there has been no depressive disorder, still that is classified under bipolar affective disorder because it is assumed that any time in life the person might have depressive episode also. So that always goes into bipolar affective disorders. When you talk about cyclothymia and dysthymia, cyclothymic is that there is cyclic like one after another or 2 episodes of mania and then depression, and usually the characteristic symptom of bipolar affective disorder is that in between the 2 episodes the person may be completely asymptomatic. That means there may not be any residual symptoms left. Most of the time person might be suffering from a manic episode for 3 months, 6 months, and after that there is complete recovery, and another episode may be after few months or after few years, and nobody will know that this person had been suffering from mania or depression.
And the other important aspect is that this classification which is mentioned by Mrs. Kalra, why do you need to know as nurses? Because in some of the hospitals there is a practice that they only write the number. They don't write the, they may write F38 or F34. They may not write the diagnosis so that it does not have legal hassles, because the relatives may misuse it to the court of law and take away the property or whatever problems could be there in the family. That is one thing. Second, it is internationally the same way used. So it is important for you to know that when you are interacting with the international community, even or reading any research article in the net, you would know that what F38, F34, F32 means, and that is why it is important for you to know that ICD-10 classification, what it indicates and what are the ways to interpret it. Now that's one important aspect, and I thought we could go into the mania and its type in further detail, and Annie, would you like to elaborate on that and also mention us about the signs and symptoms in depth? Of course, Mrs. Kalra mentioned a couple of them while discussing, the classification, but we would like you to discuss classification in detail and also the signs and symptoms.
Thank you, ma'am. Mania is a state of euphoria. What is euphoria? It's already explained by Madam Kalra, and it is also associated with increased activity and related characteristics. As Professor Kapoor has already mentioned, mania is characterized by three main symptoms, which is known as triad symptoms of mania. That is elated and unstable mood, increased pressure of speech, and increased psychomotor activities. Coming to the types of mania, it can be explained under three headings. That is hypomania, acute mania, and delirious mania. Hypomania is also known as stage 1 mania. It is a mild form of mania in which the person just feels great. It is not necessary that patients with mild mania come to the hospital, because most of the time it goes unrecognized and undiagnosed, in which the patient mood will be cheerful, moderate, elation will be present, and the individual, as I have said, he feels simply great. Patient has increased assertiveness, and there will be increased self-confidence, and an air of self-assurance will be there in the patient. The person will feel that I can do anything and I feel great, and also he feels that I am capable of doing anything. He will spend so much money, like Madam said, that he thinks that I can do so much things and which will not work out later. The thinking will be very fast, and there will be delusion of grandiosity. Delusion, as you already know, it is a belief which is not correct, and false fixed belief, in which grandiosity, like patient is feeling that I am a very powerful person and I have very high powers, I am having godly powers, so the person is having delusion of grandiosity. And the person will be uninhibited in the approach. He will be free, he will be demanding, and he will be having so much demanding in speech and in the manner. Then the sleep will be slightly decreased, and the person will not feel tired also. Appetite will be voracious, but the person does not feel time to eat. Patient will be bright. He seems to be intelligent and highly sociable, and he will be introvert, and he cannot tolerate any type of criticism. And there will be mild aggressive nature will be there. Person will be very argumentative, and he spends money. He will be full of ambitious schemes, and patient will get bored easily, and he will not stick to any particular work. He will do lot of goal-aimed activities, but he will not finish the activities. So these are the characteristics present in a mild manic patient. And when it becomes, these signs and symptoms becomes moderately increased and severe, it is known as acute mania. In acute mania, there will be marked impairment in the functioning of the person, and many times the relatives will not be able to control the patient, and they will bring the patient to the hospital, and in such condition patient needs hospitalization. Here patient will be euphoric, patient will be elated, and mood will be changing easily, which may change into irritability and sometimes sadness, and sometimes there can be episodes of even crying also in the patient. Then regarding the stream of thought, it will be increased. There will be rapid flow of ideas. As you have studied, flight of ideas will be present in the patient. There will be crying association, that the patient will be talking in rhymes. Then patient will be very noisy, very hilarious, and from a distance itself you will be able to make out, yes, this is a patient of mania because of these triad symptoms. He will be very demanding, he will be revengeful, he will be arrogant. Again there will be delusions of grandiosity. Again, delusions of paranoid ideas also will be present, that the patient will be suspicious, and he will get aggressive, he will get violent if somebody else will be talking about something else, but there will be ideas of reference also. Patient may get violent, aggressive with others. Then spending extravagantly will be there, they will spend a lot of money, and psychomotor activities will be high. Patient will be very overactive, very violent. He will, like grooming will be more. Patient will decorate himself with medals and beads, etc. And according to the season or not according to the occasion, he will dress. He will dress up extravagantly, and you will be able to make out a patient of mania from the way of dressing, grooming, appearance, etc. Again, sleep will be very little in acute mania, and the patient do not feel tired. And they will be having cuts and bruises, but they will not give any importance to this aspect also, and they may not take any treatment for these cuts also. Appetite is again increased, but the patient will not eat properly. Why? Because patient does not concentrate on eating, sitting and eating a meal, and patient becomes sexually and socially uninhibited. Regarding attention and judgment, attention span is decreased, and judgment is markedly impaired in the patient. Person will not be able to make proper decisions at times. If the acute mania phase goes unnoticed, it can lead to delirious mania. It is a severe form of the disorder characterized by severe clouding of consciousness. There may be hallucinations, there will be delusions present in the patient. And this stage is extremely dangerous for the patient as well as for others. Nowadays we rarely come across delirious manic patients, because in the acute stage itself they come to the hospital, and there are different modalities of treatment which can successfully cure the patient and make the symptoms less.
I think just to sum up, we have a slide saying that mania and acute mania, the patient will have mood which is cheerful. Can we have the slide, please? Mood which is cheerful, expansive, as you said, irritable, euphoric and elated. Both of you mentioned that. You also mentioned that at the knowledge level or at the content level, they will have delusion of grandiosity. They will have at the content level flight of ideas, at the progression level, and they will also have the paranoid idea, suspicious of people, and marked hallucination. Hallucination may come in the later stage, but not in the beginning stage. They will have increased psychomotor activity, extrovert, very sociable, uninhibited in sexual approach, and also increased libido, excessive spending and insomnia. And as you very rightly said, we remember one of the women came with her husband, and her husband was a medical professional and a practicing doctor, and she said that he was earning so much, we did not realize that the money is going somewhere, but he would treat all the patients with cold drinks, with foods from Narulas and all, until we found that the bank balance was zero. And that's where they realized that the husband was suffering from some kind of psychiatric disorders, and brought them to him to the psychiatric emergencies. Similarly, overactivity is so much that they get so fatigued, but they still are not able to sleep because of the insomnia. So with this, let us just go back to psychodynamics and talk about the nursing management, Mrs. Kalra. And when we talk about the psychodynamics, we also say that these people experience a loss. A loss which is a significant. Though these children are very wanted, they are very goody-goody people, and they are liked by everybody in the family, but there is something which is they keep on repressing in themselves, is their ego. And that's the reason, when this loss occurs, they may get into depressive reaction. But if the significant person is lost, and also they are not able to control their emotions as a goody-goody person, and they rebel it out and they become excited. So having known the signs and symptoms and the psychodynamics, what is the nursing management of patient, specifically to the nursing needs? Because you have mentioned so many symptoms: increased activity, grandiosity, hallucination. What will be our role as nurses to help these patients to control themselves and also not to cause damage to others?
Thank you, madam. Before we go into nursing management, I think we can just quickly see what is the medical management of mania.
Okay.
And when we talk about the medical management of mania, we have got very good drugs available. There was a time till 1950s there were no drugs available, and it was only 1936 that ECT came. Before that, there was no treatment available for mental disorders, and most of the cases went into chronicity. But now with good drugs we are able to control, and under the drugs which are available we have got mood stabilizers, or we call them as anti-manic drugs. And the one which has been used most widely and since long is lithium carbonate. Lithium carbonate is one drug which not only helps to control the illness or treat the illness, but it also helps in preventing the further episodes. We have discussed that there may be recurrent episodes of mania. So in case a person is in that state, then the patient is put on lithium not only to control but also to control the further episodes, not only to treat but also to control the further episode. Lithium carbonate is available in various trade names like Lycab, Ascalith and all, and the usual dose range is 600 to 1200 milligrams per day. Another drug which is there is carbamazepine, which is 400 to 1600 milligrams per day. And you also have sodium valproate. Carbamazepine and sodium valproate you must be familiar with. Carbamazepine is more commonly known as mezitol or tegretol. These carbamazepine and sodium valproate are basically used as anticonvulsant drug, but they are also found to be effective in controlling the affective disorders. So it is not that the patient has got the convulsions because of which it is being given, but it is to treat the affective disorder that these carbamazepine and sodium valproate are being used. And especially if lithium is not effective, many patients are being put on carbamazepine or sodium valproate. Then we have got another group of drugs which is antipsychotics. Antipsychotics we also use in schizophrenia, which you must have learned in the previous chapter. There are different types of antipsychotics. We have typical antipsychotics and atypical antipsychotics. Typical antipsychotics like chlorpromazine is the one which is very effective in manic disorder. Wherever there is hyperactivity, chlorpromazine is used. Then you also have other drugs which are available, atypical type of antipsychotics. Then there is another group, that is benzodiazepines, which are used. Then electroconvulsive therapy is used. ECT you are going to learn in detail further also in the other this thing. But one of the disorders where ECT is found effective is the manic episode, and also definitely in depression. Then psychotherapeutic treatment, the environment which is provided, that also is important. Then when we talk about the nursing management, we are going to talk how we control the psychotherapeutic environment, especially like just to say simple thing, that if you keep two excited patients together, you are going to be in trouble, because both of them are dominating, both of them want to control the environment, and both of them want to have the leadership role. So they are going to lead into frequent quarrels. So
the other way around also, earlier we used to say it doesn't matter if depressive and the excited patient is together. But now we have seen over a period of time, even to put a very depressed patient and a manic patient together is not a good this thing, because the self-concept of the patient who is depressed goes lower and lower and goes into more of a depressive dips. So that also, this is what is very important when you listen about nursing management. Yes.
Yeah, coming to now the nursing management. The nursing management can be discussed with with the help of various nursing diagnoses. You have learned about the basic skill of assessment, the nursing process, the steps of assessment, nursing process have to be followed. When we come to the nursing diagnosis, the common nursing diagnosis which are there based on the symptoms that the patient present is, first is altered physical activity, or we call it as hyperactivity. Another one is accelerated thinking and speaking. And then is delusional thinking, which is mainly grandiosity, but they can be also paranoid delusions which have been talked about. Then inability to care for self. Another one is impaired social interaction. Though they are talking to all, but they are not, their talks are very superficial. They are not able to have a deep relationship with others. Then altered sleep pattern related to hyperactivity. We talked about insomnia and the symptoms. So the nursing diagnosis is altered sleep pattern related to hyperactivity. Then inadequate nutrition, less than body needs, related to hyperactivity leading to loss of weight. They are hyperactive, they have a lot of activity being performed, but when you do a lot of work, you feel hungry also. They also feel hungry, but they are not having time to eat. Now we can discuss the nursing management taking one nursing diagnosis, talking first about altered physical activity or hyperactivity. When the person is hyperactive, it is not that these people are having lot of productivity. Since they have flight of ideas, their goals keep changing. They are not fixed at one goal, at one target. Since they are not fixed up at one goal or one target, their goals keep changing. They will start with some activity, leave it in between, and then start with another activity. So they are not able to complete any task. As nurses, what is our important role is that we need to channelize the energy. The more energy that they have has to be put it in some productive way. How do we channelize the energy is by providing them with the opportunities the energy can be released, like taking them for outdoor activities, making them to play football, making them to play, do certain activities where a lot of energy is being consumed, or maybe sometimes asking them to distribute the diet when they have to do. That helps them to satisfy their leadership role also which they want to take, and also it requires energy when they have to go from one place to another, keep distributing the diet.
So the other important thing in relation to this I thought I could mention here is that even for the outdoor activity or while distributing the diet, the nurse therapist should be around.
Yes.
Because sometimes even playing football they may injure because of the excitement to self, or taking a revenge on another person because the thought process is getting affected. Similarly, or if some other patient says, hey, come on, how are you playing, and that triggers their anger and increased activity and emotions, and they may hit. And similarly, while distributing the diet, if some person says, why have you given so less to me, give me more, and that again triggers up the anger. So a nurse therapist should be there when such channelizations are being done.
Yeah, it's very important. You can't leave these patients alone. And also since they are hyperactivity, they need more space.
Yes.
You cannot put them in a seclusion room, not just keeping them locked in a room. They are going to become very aggressive, because usually what happens in the families is when the patients are at home, most of the times the patients may be brought tied in ropes and chains. The problem which comes is because they are hyperactivity and they are trying to control the motor activity of the person, they might try to restrict. They have to be provided with an open space, with a lot of space to move, but at the same time the environment which is provided should be safe. You cannot have the things by which they can injure others, like small furniture which they can pick up and throw, or having the sharp instruments like knife and other things, or the glass pieces. These things have to be avoided, and many times in psychiatry ward we do not permit them to have the glass utensils and other things. It is preferably the plastic things which should be used.
Annie, what do you think, how will you help the nurses to help the patient about the grandiosity, if the person has delusion of grandiosity?
Okay, the patient is saying, I am feeling great, or I am Prime Minister, I can do this, sister, don't you feel so? The nurse can be either ignorant to the delusions the patient is having. It is always better not to argue with the patient, that you should not say that I don't feel so, or I don't think so. That may make the patient more aggressive. So it is always, if the person is in a state to understand, you can say, yes, I know that you feel this way, or you think this way, and it is part of your illness.
Good.
It is part of your symptom.
Yes.
That you think that way. So later on with the medications, you will be all right.
Like sometimes they might say that I am Prime Minister, and sometimes as nurse you may try to take the newspaper. See, in the newspaper there is a photograph of Prime Minister. This is the Prime Minister. When we talk about delusion, in the definition itself, it cannot be corrected by any logical reasoning. So it is no use that you try to, that is going to make the person feel low, and the person is going to become all the more aggressive. You don't have to argue with the delusions.
If the patient has a self-care deficit of not eating, food because they have less concentration, hyperactive, do not have time, which you have been time and again mentioning. So how are you going to help these patients?
Yeah, these patients, as we said, they are hyperactive. They need a lot of activity. They need a lot of food, but they do not eat. So what is best is that to provide them with finger foods. Finger food is something which they can pick up and they can eat. They don't have to sit. Like if you serve them with rice and dal, the person cannot pick up in the hand and eat. But if you give them stuffed paranthas or the sabji rolled in parantha, or you give them some sandwich, they can pick up, they can eat. That is the best way to serve.
Right. I think we can spill it over in the session 2 when we talk about the depression, and if any one of you have a questions to ask on management of patient with mania, I think we can discuss under that also, because the next session what we are going to have at 1 o'clock is about nursing management of patient with depression, because a part of psychodynamics remains the same, and we will straight away go into nursing management of patient with depression. So if you have any question related to mania, nursing management, please ask us at 1 o'clock when we resume back. 1 to 1:45 we'll be discussing about that. Please stay with us and join us at 1 o'clock.